everyone. Welcome. We're so glad you're here for today's webinar, Psoriatic Arthritis and Obesity, What You Need to Know. I am Jenny Dunn, the Director of Marketing at NRF, and I'll be your moderator today. So before we begin, I want to extend a big thank you to our sponsor, Lilly, for making today's webinar possible. We truly appreciate their support in bringing these conversations to you, our community. A couple of housekeeping notes. This session is being recorded and you'll be able to watch it on demand on the ANRF website. And we would love to hear from you today. So at any time, please drop your questions into the Q&A box, which you should be able to see. And we will get to as many as we can at the end. Today, we are tackling an important topic that's often overlooked, the connection between psoriatic arthritis and weight and what it means for you. So we'll be breaking down the science, exploring the real-world experience, and discussing practical steps that can help you feel your best. We have an incredible group of speakers with us today. So we have Dr. Heather Faust, an ANRF alum and a researcher who studies how inflammation and weight intersect. We have Dr. Catherine Bakewell, a rheumatologist who specializes in PSA care, and Jason, a patient partner who has lived this journey and will be sharing his experience with us today. Before we jump in, I'd like to start with a quick poll. So I'm going to launch our poll here. I want to hear from you. Have you ever talked to your doctor about how weight might affect your arthritis? So there's a yes and a no option. Will you just drop your answer in there and we can see how are we all feeling about this subject? I'm seeing, honestly, about a half and half split of little less than half of you saying yes, a little more than half of you saying no. And here we are, we've arrived. I'm going to end our poll. It's a 50-50, so I'm really excited to see what we can learn today from our presenters. So let's get started with the science behind it all. Dr. Faust, I will hand it over to you.
Great. Thank you, Jenny. I'm really excited to be here today and talking to you about this important science. So my name is Dr. Heather Faust. I'm currently an instructor at the Brigham and Women's Hospital. And just a fun fact, when I was in high school, I drew a lot of bones for my AP studio art class. And little did I know I would be working on knee joints in my future. So just to a quick word about psoriatic arthritis to acknowledge, it is a very multifaceted disease. You can get finger and toe swelling, of course, skin aspects and nails. It has negative effects on the quality of life. But today we're going to really be focusing on the joint inflammation and degeneration and possible mechanistic links to obesity. And so I just have a little schematic of a knee joint over here with these little blue cells representing immune cells such as T cells. So psoriatic arthritis is very similar to rheumatoid arthritis in that they're both inflammatory autoimmune forms of arthritis where your immune system is really attacking your tissue. So in this process, your joints become inflamed. The joint tissue, such as your synovium, really gets swollen, and it leads to joint destruction and bone erosion. So these immune cells can come in and the cytokines that they secrete can activate other cells to secrete cartilage degrading enzymes, which leads to joint degeneration. And currently there are some biologics, including, this is the last bullet point here, anti-TNF, anti-IL-23 and IL-17 treatments are available to help patients with this, but not everyone responds. And these aren't targeted or tailored towards people who also have other comorbidities such as obesity. So just to start talking about this, so obesity is a major risk factor for arthritis. And this is even in non-load bearing joints like your finger digits. So we know that obesity is not just exacerbating arthritis because of the weight bearing. We know that this must be another systemic factor due to obesity, either through the immune system or some other way. And so, we can see, just to emphasize here how the arthritis gets worse, we see that in obese patients, they have worsened synovitis. So that's inflammation in their synovium, the joint tissue. If we look over here on the right, you can see the top image is a histological section from a lean patient with rheumatoid arthritis, and the bottom is one from an obese patient with rheumatoid arthritis. And the red staining here is what we're looking for. This is staining some immune cells. So I think you can appreciate that there's far more cellular immune cell infiltrate here in the obese patients. In addition to this worsened synovitis, obese patients attain lower rates of remission compared to lean patients, so almost 50% lower. And when we think about reasons why this might be happening, we know that adipose tissue, and so I just have a schematic here on the right. These big yellow cells are representing adipocytes, which is the main cell type in the adipose tissue. And you can see in the lean state here, it's mostly anti-inflammatory. But then on the right, as it gets more, as each adipocyte gets fuller of lipids, they expand and then they can actually burst. And this drives inflammation during obesity. And so immune cells like activated T cells and macrophages can come in and really start driving this immune response. And then this can also lead to the release of systemic mediators, such as adipokines. You may have heard of leptin, resistin, vispatin, and this can lead to systemic activation of immune cells. And as you can imagine, this can impact your joint inflammation. So I'm just showing, and as an example here, the effects of one of these adipokines, so leptin. It can have impacts on your brain, so it does hormone regulation. It can have direct impact on cells of your joint, as well as many other aspects, including here you see there's major impacts on your immune cells. So that's one way, is through inflammation. Although other links between obesity and inflammation includes the fact that obesity strongly leads to type 2 diabetes and insulin resistance. So insulin resistance and insulin exposure in general can impact immune cell function and drive them to be more inflammatory and invasive. In addition, here I have listed the high fat diet. So obesity is usually associated with someone having a high fat or Western diet. And this diet is known to increase the permeability of your intestinal barrier. And this can lead to altered composition of the microbes in your gut, including increased entry of LPS-bearing bacterial species. And this can also lead to systemic inflammation. So these are still also tied to the immune system, even though I put them in a different category. Human data supports the effect of weight loss on reducing arthritis severity. So I'm showing here a really nice study from Jeff Sparks' group. Patients had bariatric surgery, and then they assessed body mass index and rheumatoid arthritis disease activity 6 months, 12 months, and further out. And you can see there's a really nice reduction in the BMI here in the graph on the left. And then on the graph on the right, you see it almost entirely tracks that the disease activity goes down along with the weight loss. And so, other considerations to improving arthritis that we can control would include taking something like prebiotic supplements. They may help and have been shown in some mouse studies to help reverse negative effects of high-fat diet on your gut microbes. And some studies have even showed some cartilage protective effects, which is great. Also adopting a diet lower in fat. I think Dr. Bakewell is going to talk more about some of these things in her part of the talk. And also low impact exercise are great options for anyone trying to lose weight. And then, this kind of leads into this new option for everyone trying to lose weight, GLP-1 agonists. So I just want to take a second to talk about how they work. So the glucagon-like 1 peptide is released after eating, and it basically stimulates the pancreas to release insulin and inhibits glucagon secretion. So this acts to lower blood sugar and it reduces the appetite, which is how the GLP-1 agonists, which mimic GLP-1, that's how they help aid in weight loss. And currently, no research has been done to assess the effect of GLP-1 inhibitors on arthritis, but they show great promise to reduce the effect of obesity on arthritis severity. And there's already some early studies showing that this can make a difference in patient-reported outcomes. And I believe that's my last slide. I'll hand it over to Jenny.
Thank you so much. Thanks for taking us through the science of that. And now that we've heard the science side, I'd love to bring it to life with a real world perspective. So I'd like to introduce you to Jason, a patient partner who has firsthand experience navigating psoriatic arthritis and the weight challenges that can come along with that and the emotional toll, of course, that comes along with it as well. So Jason, would you share your journey with us?
Yeah, I'd like to thank Dr. Faust for explaining what's actually happening inside my body. I don't understand all of it, but it's nice to get a clue of what's happening. Um, uh, if you're for the people out there, raise your hand if you have shoes on. I know I can't see you, but raise your hand if you have shoes on that don't need to be laced up. Uh, I have lace-up shoes, but I tie them before putting them on. Then I slip them on with the shoehorn. Nothing worse than having a shoelace become untied while I'm out somewhere because being overweight and having psoriatic arthritis, getting down to those shoelaces is pretty tough. Uh, Raise your hand if you don't hurt as much while you're eating. For me, I for some reason, I don't hurt when I eat. It's the only when for a long time, it was the only thing that made me feel better was enjoying a nice long snack on the couch. And I even noticed I was eating while I was doing things so I could do things a little bit longer. And it's pretty bad, but and then raise your hand if you miss one day of work or more this month due to the pain of psoriatic arthritis or a flare up. And I for one was missing a lot of time at work, and it was getting scary about keeping staying working. Did put up the picture of me. There we go. This is me, about 380 pounds. This is they asked me for a before picture, and this is one I came across, and it reminded me of a story. So I've actually was a little bit bigger than this, but about 7, 8 years ago, my companion wanted to go hiking. This picture was at Arches National Park, and she wanted to do some hiking. She thought it would be fun, and for me, hiking was the least bit fun that I could have. But I want to be a nice person, and she wanted to go, so I got my hiking poles to keep from falling because falling while you're weighing 380 pounds is bad, not good. We went on the trip. I was able to do a couple of hikes, what I call hikes. It was like if I stayed on the flat, maybe 10, 20 minutes, maybe 10 minutes out, 10 minutes back. And that was about all I could do. That was a hike for me. And so she had to go along on her own to actually hike. And I looked through my binoculars and took pictures and tried to have a good time. And then I just sat in the car and I waited for her to return. And I remember feeling that, hey, I'm at least trying, and maybe someday it will be better. But I also remember feeling left out. I was not able to do the things that all the other people were doing out there. I was sitting in the car. A few years after this picture was taken, I had to have total knee replacement surgery due to the permanent damage in my knees from the psoriatic arthritis and my weight. And, the damage was done. unreversible damage was done. It just had to be changed with surgery. I how I when I started getting arthritis, it was I got the white scaly patches on my knees and elbows. They started about 30 years ago, and it didn't hurt or keep me from doing anything. I just covered it up and left it alone. And then about 10 years after that, 20 years ago, I started having soreness in the same joints, like the patches in the elbows. My elbows hurt, patches, white patches on my knees. My knees hurt. I went to a rheumatologist who diagnosed me with hardening of the tendon ends. And I recently checked out the www.curearthritis.org website. That's .org. If you go to .com, you won't get there. And downloaded one of the many fact sheets available. This one labeled "What is psoriatic arthritis?" and it listed hardening of the tendon ends as a symptom of psoriatic arthritis. And I did not know that till just now. But back then, 20 years ago, you had two different conditions. You had psoriasis and you had arthritis, requiring two different doctors prescribing two different treatments. And it was not coordinated at all. And the treatments I've tried creams and ointments. I can't count how many creams and ointments I've tried on the scaly patches. And I even tried the UV therapy that was experimental back then. I've been for the pain and for the other stuff. I was been prescribed NSAIDs, aminosalicylates, antisporatics, pain medications. I've had the cortisone shots. I even tried the biologicals, the expensive biologicals, and some medications worked better than others, but eventually they just did not do a good job at reducing my pain. About 15 years ago, I was lucky enough to get picked up by a rheumatologist, Dr. Catherine Bakewell, and she started treating me for just one condition, psoriatic arthritis. Uh, and with her treatments, and following her recommendations and taking her the medications she's prescribed, we've gotten it down to I had 95% less white patches on my body, and the pain in my joints had decreased enough for me to keep working the whole time, which is, earning a living is very important to me. About 6 months ago, I started to have problems with my hips. My knees were good, but my hips and lower back was getting the same thing. And I'm getting worried. Here we go again. And my rheumatologist noticed that I had not lost any weight for a while. I lost some weight, but it just plateaued about 340 pounds. I plateaued. I just stayed there for a year plus. And she suggested that I could try a GLP-1 to help me get my weight loss started again. And let's see. And that may reduce pain and help prevent further damage to my joints. So decided to try the GLP-1. And the results I got, I've only been using the GLPs for a little over 4 months now, but I've lost over 10% of my body weight, already losing 40 pounds. I'm now down to 302 and still losing. I'm getting very close to my first goal of being under 300 pounds, which is going to be awesome. I'm trying hard. I'm feeling less pain in my hips, and I notice I'm beginning to stand up straighter, which is nice when I walk. Because I'm a security guard, I have to look authoritative. And since using GLPs, I feel full while eating. And normally I'm a slow full guy. So by the time I feel full, I've way eaten. And now with the GLPs, I feel full when I am full, and it's a lot easier to stop, push away from the table. I have almost zero white scaly patches on my skin, which was I didn't expect that at all to happen. And losing weight has helped me keep working. I've not missed a day at my job to a flare up for a while now. I still have the flare ups, but they're shorter and less. Instead of being a week long flare up, it's sometimes only a few hours. It's less than a day, and I'm having these short flare ups, and I'm able to get through them a lot easier. And one thing I did not expect after starting the GLP medication and losing weight was that my mental health improves so much. I'm less stressed, I'm calmer, and I feel more confident in myself. I'm standing up straight, and I feel confident, and that's nice. That is helps me at work, helps me do my job, and it just feels better to feel confident when you walk into a store or something that you can actually walk in there. Uh, but I'm not relying on the GLPs alone. I'm trying to eat healthier and just normal. I don't eat chips, soda, fries. No processed food. That over processed food really sets off my condition. So I've tried to get away from all the over processed foods that I can. Now this is a picture of me. I still weigh a lot. I got a lot of weight loss to go. I'm still 300 pounder, but it's getting better. And I chose to be in my uniform because I just wanted to show that it's very important for me to continue working. Continue to work is the one of the most important things. I got to support myself, got to work. And I'm continuing to work closely with my rheumatologist and following the prescribed treatments and advice he gives me. And that's going to be the key to reducing joint pain and preventing further damage to my joints. I'm glad my rheumatologist was knowledgeable and cared enough to suggest that I try the GLPs. And I encourage you to talk to your physician, your rheumatologist, and ask them if the GLPs are something that would be good fit for your condition. And do this sooner than later because every day that you're go through this condition without treatment, without and not losing the weight, you're having long-term irreversible joint damage is occurring to your joints. And that joint damage that doesn't come back. So the sooner you get on, early diagnosis and treatment are key to having a healthy, productive lifestyle for someone diagnosed with this psoriatic arthritis. And thank you. And I will turn it back over to Jenny.
Thank you so much, Jason. I know so many people here can relate to what you're saying. And to that end, if you have questions for Jason, we have this really great opportunity to speak to not only the patient, but the provider as well. So please do start to put your questions in that question box. We will get to as many of them as we can after Dr. Bakewell's presentation. So, Dr. Bakewell, you have worked with Jason throughout this process. We would love to see what this has looked like from a clinical perspective. So I'll turn it over to you.
Absolutely. Thank you, Jenny and the ANRF for the opportunity to speak with you all today. And thank you, Jason, so much for sharing your story. I think it's a very brave thing to do to get up and share your story. And hopefully it does resonate with some of you on the line. And I really want to underscore how proud I am of Jason, not only for being open to, giving the GLPs a try, but he really has worked very hard to stay away from sugars and processed foods and to kind of balance that lifestyle with the medicinal intervention. And so that's kind of what my next talk is about. This the focus of today's webinar really is truly on Jason and to give each of you an opportunity to ask your questions. I think Dr. Faust and I are here to just touch on the research and the science such as it is, but I don't want to take that much time today, so I'm going to try to breeze through these slides. I want to just start off by saying it is in place for us as providers to be talking with you, our patients, about weight because it does have an impact on arthritis, just like Dr. Faust showed us as a driver of inflammation and mechanical damage in load-bearing joints. And so there, the American College of Rheumatology, the National Psoriasis Foundation, GRAPPA, which is this group for research and assessment of psoriasis and psoriatic arthritis. All of these organizations recommend the provider encourage patients to maintain a healthy weight, again, to improve disease activity and minimize disease impact. Here, let me move ahead. But we'll go. There's always a couple second lag. Please forgive. I think there's a question in our minds as providers. How much should we be focusing on wellness? And we've had a tendency in the medical system, obviously, this is just a little cartoon, like we're all kind of lining up for, toxic pills and surgery. But the reality is the whole medical system has probably not focused enough on wellness and lifestyle change as a tool for helping people manage their weight. And here, what you're looking at is, according to obesity medicine, specialists and experts, what we're calling the four pillars of weight loss and obesity management. And the first one, as it should be, is diet and exercise. And this is obviously available to everyone and all of us. We should all be kind of thinking about these things in our day-to-day lives. What we call psychological and behavioral intervention refers to some people will benefit from CBT or cognitive behavioral therapy, talking with a therapist, really focusing on what are our triggers to eat or overeat, what are the narratives that we tell ourselves around food or about our weight or our health in general. But also it's simple things like, are you getting enough sleep? Research shows us that when we're sleep deprived, we're hungrier and we overeat through a release of cortisol. So this is a hormonally mediated phenomenon. Also, are you thinking about where your next healthy snack is coming from? Are you packing with you throughout the day something that you feel like would be good for you to eat when you get hungry? Because otherwise, we all will grab if there's, the party in the office, or we'll grab the donuts or the cake or whatever is there in front of us, or whatever's in the vending machine if we haven't thought ahead to bring the snack. So kind of planning, focusing on stress reduction, sleep management, and thinking about where that next healthy snack is coming from. Then we have as further options when those two things have failed, pharmacological interventions, and this is a field, again, probably why a lot of us are here. This is a field that has truly exploded in the last couple of years with a lot of new exciting options. And so we'll take a look at what that is and where that fits in. And last but not least, surgical interventions. And this is more a call out to our primary care doctors and our specialists, our rheumatologists, to remember that we are part of a community. So you don't necessarily need to get these medications from your rheumatologist. This can be an endocrinologist or another weight loss specialist. And either your rheumatologist or your primary care doctor could be referring you specifically to a dietitian or nutritionist, an exercise physiologist, physical therapy. There's all kinds of resources within the healthcare system that should be made available to you. I like this slide. This is a snapshot from a year in review, and this was one of the few slides or research trials that I've seen that looks very specifically at which diet is best for psoriatic arthritis patients. And what it shows, unfortunately, is that what we consider our Western diet, which is high sugar, moderate fat, does increase our psoriatic arthritis disease activity. So they were actually worsening psoriatic disease by adhering to the Western diet, if you will, the traditional Western diet. Now, if you go through these other kind of ketogenic, gluten-free, etc., they may be helpful for specific populations, but a lot of these other diets, the benefit is limited to the weight loss alone. So there's not additional benefit to that particular diet, with the exception of the Mediterranean diet. You're all likely familiar with this. This is a plant-based, lots of fish, very little red meat, maybe some white meat, so high in omega-3s and plants, essentially. And this was associated in this trial with decreased psoriatic arthritis disease activity scores, independently of the weight loss. And there's another abstract coming out from this group at our big annual scientific meeting in Chicago this October, and I will be front and center at that because because I want to see what it shows us. The same group has been able to demonstrate increase in psoriatic arthritis activity with high sugar intake specifically. And that's something that some of my patients have been telling me for years, and I hadn't seen the data, and so I was a little skeptical. Is this a real phenomenon or not? Jason figured it out before before the research did, right? To stay away from higher sugar loads because it can make the arthritis worse. So here, in case, another proof of concept for those skeptics that are out there, this actually has been studied in a very scientific way, looking at, in this instance, caloric restriction and weight loss and its impact on various aspects of psoriatic disease activity. So both just the psoriasis itself with decreasing body surface area here in this little green graph to overall psoriatic arthritis activity scores from baseline all the way out to month 6. The health assessment questionnaire focuses on patient functioning and how disabled we are by the arthritis, and then how many tender and swollen joints the patient had. All of these decreasing as weight loss drops, or I should say weight drops over time. And this is a call out primarily to our physicians, but to all of us that as we think about wellness and exercise, and we have someone around us who is encouraging us, it actually does impact our behavior. So, yes, it's good if your doctor talks to you about this, but if your doctor isn't, please feel free to proactively bring it up. And we're going to talk about that as well. But have an accountability partner. If you're like, okay, I'm going to get to the gym, 3 days a week, whatever the goal is that you set for yourself, talk to your spouse, talk to your friend, make sure that they check in with you to see if you've actually accomplished the goals that you set for yourself, because it will increase the likelihood that you stick to the goals that you have set for yourself. We all need some help in that regard. What should we be doing as far as exercise? So this is from the American College of Sports Medicine Physicians and the American Heart Association. And even our Surgeon General several years back said, okay, 30 minutes of moderate intensity aerobic activity for 5 days a week. That's kind of the like for everybody across the board. And what that means is I don't want you so breathless that you can't carry on a conversation or can't say a sentence. But I do want you a little breathy. I don't want you to be able to have that conversation with your best friend, no problem. So whatever gets your heart rate up high enough that you're having to work hard, right? You're breathing hard. That's that sweet spot. That's where you want to be. Now, if you've probably seen the HIIT exercise, the high intensity interval training, it actually does yield more benefits. And the recommendation as far as how much time you have to spend goes down. So they're like, well, if you want to do vigorous aerobic activity, now you're only looking at 20 minutes 3 times a week. So I think that's helpful to know. And they're not necessarily recommending that you do less, but it brings home the point that the harder that you work within reason, be safe. You can get clearance from your doctor that is safe from a cardiovascular standpoint, for example. But the harder that you work, the more bang for your buck, so to speak. You can break this up. So if you don't have 30 minutes, 5 days a week, if you have 10-minute intervals before work, during lunch, after work, absolutely, those 10-minute intervals count towards that 30 minutes a day. And to not forget that we are creatures in a whole ecosystem, and wellness is much more than just this physical aspect. You need to be paying attention to your mental and emotional wellness, to your social connections, to your environment. How healthy is your environment? So sometimes helping a patient with their wellness isn't just focusing on this physical aspect. And that's something that we let ourselves get pigeonholed maybe into in Western medicine. So this is a fun slide. I don't want to spend a lot of time on this, but this was something that I didn't know until I started to delve into the research surrounding adipose or fatty tissue. So there are different kinds of fat cells in the body. Adipocyte is the scientific term for a fat cell. And the white adipocyte is the kind that we think of as fatty tissue. So this is the kind that it's there to maintain your warmth, in colder temperatures, and it will put on more fatty acids as you eat that high fat diet. So this is where Dr. Faust was referring to these cells growing, becoming engorged, rupturing, releasing these toxic free fatty acids. So these are the inflammatory cells. But as we eat a lower fat diet, we can actually have a transdifferentiation into a beige adipocyte. And these are metabolically active cells. There are higher mitochondrial counts, and they can actually help us lose weight. They help us burn fat, interestingly. Now, a different cell lineage, we have these when we're born, is these brown adipocytes. And these throughout our whole lives are very packed with mitochondria. And they will always be metabolically active and help us burn fat. And so the question is, how do we increase this type of fat, the good fats, right? And the answer, interestingly, some of the answer lies in colder temperatures. So there's all this, and we don't even need to get into this in case people are curious, but there's all cryotherapy, cold plunges out there, and then, of course, exercise. So we can change our fatty metabolism or makeup. So you've heard me mention this, and Dr. Faust, the BMI, which refers to a body mass index. And the way you can calculate this, so the way that you would do this is you take your weight and your height and you plug it into a formula. And so normal or healthy would be considered under 25, whereas once we go between, 25 and 30, that would be that patient would have overweight, whereas over 30 would be that patient has obesity. And we're looking at, so are you, if the question for those of you in the audience is, am I a candidate for anti-obesity pharmacotherapy for weight loss medication? And the American Heart Association says, yes, you are, if your BMI is between 27 and 30 and you have what's called comorbidities. So that's high blood pressure, obstructive sleep apnea, history of cardiovascular disease, diabetes mellitus type 2, hyperlipidemia. So anything that would be considered a downstream sequela or result of having overweight, you would absolutely be a candidate. It's recommended that you consider in that instance pharmacotherapy. And then anybody with a BMI over 30, you're a candidate for pharmacotherapy. And then here, the metabolic or bariatric surgery, this is going to require the presence of that BMI over 30 plus comorbidities. And most individuals would want to have tried and failed pharmacotherapy first. So when we talk about anti-obesity medications, what are we talking about? Here is the list of medications that the FDA has approved for the treatment of overweight or obesity. Starts with phentermine. This is one that we've seen for many years. It is technically a controlled substance, so the FDA labels it Schedule 4. So when you go to pick it up at the pharmacy, you have to show your driver's license. It is only indicated for the short-term management of overweight. And so you wouldn't want to be on this for more than 3 months, for example. And you have to have monthly visits with your doctor to ensure the safety of this medication. I think of this as a stimulant. So this is it's a noradrenaline releaser or norepinephrine. If you think of something that is stimulating, you sort of think about feeling a little revved up, maybe fast heart rate, those kinds of side effects would be what you might see with this. Interestingly, when you mix it with an anticonvulsant called topiramate, this is marketed under the brand name Qsymia. You can take it for longer term, but it is still a controlled substance. I want to jump down. So this is another one I've seen commonly, bupropion with naltrexone. This is marketed under the brand name Contrave. So a fair number of patients will take this. Naltrexone, interestingly, has been studied in rheumatology, as could this also reduce inflammation and pain. Again, not FDA approved for that indication. Then we start to get into, so orlistat is gastric and pancreatic lipase inhibitor. Essentially what it does is it prevents the body from absorbing the fats that we eat in our diet. And then last but not least, the incretins, so liraglutide, semaglutide, and tirzepatide. These medications are the GLP-1 agonists. Tirzepatide is the only one that is also a GIP agonist, so gastric inhibitory peptide. These are hormone mimickers, if you will, that respond the way, so these are the things that our body releases when we have eaten food. Right. So what would you expect your body to do when you eat food? Well, you want it to release insulin so that you can take up the sugars into your skeletal muscles and the organs that need it. You also want your body to sort of slow down. Now, you've just eaten. You don't need as much appetite. So these are appetite suppressants. And so this is, you can see kind of on this list, everything that these agents do. There are some other things on this slide. For example, metformin, not FDA approved for weight loss management, but it does decrease the production of glucose or sugars by the liver. So a lot of people have taken this as a weight loss management. There's some modest weight loss seen with these. So here we're looking at adverse effects, contraindications, so things you might see, again, as you would expect with anything that decreases your ability to absorb fat, diarrhea, oily stools. This is just part of the way that this medication works. Any of these medications you would not want to take if you were pregnant. So contraindication, this is just things that if you have any of these things, you wouldn't want to take this class of medication. Again, I don't want to spend a lot of time on this just because I think the focus of today really is about that conversation of you with Jason and any questions that you have. The incretins, so the GLP-1 agonists truly have changed the landscape of weight loss management over the last year or so. And so this is what we can see commonly is GI side effects. So gastrointestinal distress, stomach upset, diarrhea. Some people will have some nausea, vomiting, or a little bit of stomach pain. It tends to be more in the beginning, so right as you start the medication. And so what you'll notice if you get prescribed one of these is that your doctor will start low and go slow. So you kind of get used to a particular dose, and then over time you can increase the dose. And this works to decrease your appetite, just like Jason mentioned. It increases a sense of satiety earlier. And you do need, if you were to go in for a procedure, you need to tell your anesthesiologist about this. They may have you hold your medication before the procedure. And you would not want to take this if you have any personal or family history of what's called medullary thyroid cancer. It's just a very particular kind of thyroid cancer potentially associated with these medications. All right, so in my last minute here, I just want to say a reminder, if you go see your doctor and this particular doctor says, I don't do weight loss management, just remember to say, well, could you refer me? Right? Because an endocrinologist is technically the specialist, but there are a lot of metabolic endocrinologists where this is all they do is weight loss management. Is there a weight loss clinic they could refer you to? What about a dietitian? What about a physical therapist? And then even talking with your primary care. This is all part of a network that is there for you. So, in summary, I think Dr. Faust has given us good evidence that obesity does increase the risk of psoriatic arthritis through these pro-inflammatory mechanisms, and obesity increases inflammation. It disrupts the gut microbiome. She showed you you've probably heard the term leaky gut. There it was with that high fat diet. And it puts additional stress on your joints, all of which may contribute to worse outcomes in psoriatic arthritis and or the development of the disease itself. People with psoriatic arthritis and obesity do not respond as well to treatment or are as likely to be in remission as those without obesity. Lastly, weight loss in people with psoriatic arthritis and obesity can significantly improve disease outcomes. So your psoriatic arthritis will do better. And I've had several patients where, we've tried multiple different medications and weight loss was the missing piece to actually help them feel better and to control their psoriatic arthritis itself. And lastly, if you are an individual who suffers from obesity and psoriatic arthritis, you should consider weight loss medication or potentially surgical intervention in addition to the lifestyle changes that I mentioned. And with that, I'll wrap it up. Thank you for your time and attention.
Thank you so much, Dr. Bakewell. This has been fascinating, I'm sure, for you to just see these new treatments emerge. And I'm really grateful that we're getting such a kind of holistic view of this today. We're getting an all sides view. So we're going to move into our Q&A now. If you have not, please put your questions in the Q&A box. We have a few in there coming in already, but we're going to try to get to as many as we can. To kick off the Q&A, I think I'd like to start with a question for Dr. Faust. So we know, I guess our main question is, can inflammation from psoriatic arthritis or obesity affect other parts of the body besides joints? What does that look like?
Yes, absolutely. It can affect pretty much, your systemic, all your organ systems can be affected by the inflammation from obesity. So I think I had the schematic in there about leptin and it has effects on mostly negative effects on the brain, your heart, like cardiovascular systems, pretty much everything. Because immune cells, once they're activated in a kind of maladaptive way, they can just go about anywhere. And other specific places I can think of would be like the liver. In obesity, you can get the non-alcoholic fatty liver. And cardiovascularly, it's very bad. So really, it's very systemic. And yeah, the other experts probably know even more details than I do about each specific organ that's impacted. But definitely it can impact more than just your joints, for
Wow.
sure.
Yeah, okay.
I would love,
Go ahead.
sorry, I was just going to echo on that really quickly because I was just looking at a schematic and thinking to myself, so on this particular schematic, it listed as being associated with obesity, not only dementia, you mentioned the central nervous system, but increased risk of dementia for patients who suffer from obesity, but increased risk of certain cancers. And some of the ones that were listed were renal cancer, kidney cancer, prostate cancer, breast cancer, and the expert who was talking about the schematic was saying that there's these little extracellular vesicles that can contain pro-inflammatory mediators that can basically, all of these tissues can be surrounded by adipose or fatty tissue and then can suffer from the inflammation from being adjacent. And what occurred to me is I was like, imagine I was prescribing a medication to a patient and I was like, this medication could increase your risk of dementia and all these different kinds of cancers. Nobody would take it, right? So it's like I feel like the call out to us as healthcare providers is like, why are we not addressing this for all of our patients right out the get-go? But I think it's we didn't until more recently have the very best tools, I think, at our disposal. So I think the landscape really has changed over the last couple of years. But that's a great question.
Oh.
Yeah, actually, you jogged my memory a bit, Dr. Bakewell. I'm recalling that obesity, it's a comorbidity for many autoimmune diseases. So like including multiple sclerosis. Um, I think it's like one of the thyroiditis autoimmune diseases. I'm blanking on the name off the top of my head, but many different autoimmune diseases are also comorbidities with our obesity. Um,
Yes, that
Interesting.
inflammation link is key.
Yeah, so kind of digging a little further into that, I think there are some questions around sort of your age in relations to this, and something that came up in the Q&A box is, are there specific guidelines for people over the age of 65? And I'm thinking this is in relation to using GLP-1 medications. So does it look different for somebody who's a little older versus somebody who's a little younger using these medications?
That's a great question, and I will be the first to admit that I don't know. I think so. The question of kind of say somebody does have longstanding diabetes, if they already have delayed stomach emptying or what we call gastroparesis, that would be somebody that you would be very careful with these medications with. Um, but I am unaware of specific contraindications other than some of the ones that I told you about, which is to say that history of medullary thyroid cancer. There's another condition called multiple endocrine neoplasia type 2. That's a familial sort of a genetic thing. You would know if you had it, right? This is not something that you would be like, oh, I didn't know, unless, I guess some patients are adopted and then they don't have that advantage of knowing their family history, but it would not be subtle if that were present. So other than that, I'm unaware of any specific contraindications, but I'm also not a metabolic endocrinologist. And those are the doctors who are truly. I did notice, for example, when I was looking at the exercise recommendations, it was different so that it was kind of for people age 18 to 65. And the idea is when you're 65 and over, you have the right to go a little softer and check with your doctor about your heart and those kinds of things. So I definitely would recommend working who has a little bit less experience if you do think you may be at higher risk from any of these medications.
Okay, so it sounds like that's something to definitely take to your doctor. If you're
Yes.
considering these medications over the age of 65, maybe have those questions teed up for yourselves when you're asking about this.
Yes.
Jason, what advice do you have for someone who feels overwhelmed by their PSA and their weight?
Well, yeah, that's how you feel most of the time. That's how I felt. Um, for me, everything gets started with stress. And then, like Dr. Faust said, that stress tends to start that whole reaction out with the immune cells, the bad, you mean immune cells going through. And so you eat because it takes away that stress. But to just you got to just keep trying. I was able to lose about 50 pounds before. It went back up a little bit, but I kept 40 off just from I ended soda, fries, chips, and cheese. And just I just said it. Those are my favorites. I hate to say, and they give me good reactions, but I ended that, and I'm not perfect. Like I went down from two burgers to just one, and just try to eat less. And I still even now have a burger on the weekend once, but um, if it's overwhelming, you just got to keep trying and keep working. You take the medications. If it doesn't work, you talk to your rheumatologist or your doctor and you say, this one's not working. What else can we do? But you have to do your part. You have to try to be healthier, work, active, uh, and eating less. It's a team effort when you're working with this. So just work with your doctor and then do your part. Don't just expect the medications to just do it all for you. They're just to help you. And that's my advice.
Yeah, I mean, even I think being here on this webinar is a good a good step. Learning, taking your health in your own hands and learning about what you can ask and what you should be listening for at the doctor. This is a great step for that. I do have a question. So we're seeing a couple of questions around insurance, right? If this is a covered medication and non-covered medication, are there resources for people if this medication is not covered? What would you suggest in that situation? And I'm thinking this is a question for Dr. Bakewell, but if others have answers, you can feel free to chime in.
Yes, the issue of getting it covered by insurance has been a doozy. Because the medications, some of them are very expensive. A lot of insurances, even in our area, have said categorically that they are not going to cover the medication if it is for weight loss. Um, some tips and tricks would be, if you happen to also have diabetes mellitus and or some instances glucose intolerance. So some of the same medications are indicated for both of those conditions, and so you may be able to get it covered for diabetes, whereas they're not going to cover it for weight loss, for example. Um, Another thing that people have done is you can buy the medications directly from the manufacturing companies, particularly at the lower doses. It may be available in a vial and not a pen. And if you're willing to draw it up and inject yourself, then you're looking at something that will be on the order of several $100s a month potentially, rather than several thousand. So that makes it more affordable, although still expensive. There is the issue of compounded medications, and you've probably seen that in the news. So you can get these compounded medications significantly less expensively than you can the brand name medications. However, there's the issue of sort of how reputable is the compounding pharmacy? Do you feel like you're getting the purest product and at the dose that is being prescribed to you? So there's issues either way. But it looks like for now that with the legislation around the medications having been taken off the drug shortage list, your doctor can still prescribe you to a compounding pharmacy, but you can't buy in batch. So pharmacies and other distributors can't buy in batch the compounded medication. So it's a complicated landscape. I think wherever you can get the brand name product covered, that's the best option, right? But there are other options for people who can't.
Okay. And maybe that's something again to talk to your care team about. There can be various kind of helpful people inside of a care team to help you navigate that. So that would be another recommendation there too. Um, Something that I saw come through, and Dr. Faust, I wonder if you could speak to this a little bit. Can psoriatic arthritis cause obesity?
Yes, I was just looking at that as well. And I think it's a little bit of a complicated question because,
Mhm.
I think there certainly is a potential for psoriatic arthritis to impact metabolism. And I would say I'm not as much of an expert on psoriatic arthritis. I do know in rheumatoid arthritis, there's definitely a very large change in metabolism, and this is somewhat hormone based. But it also depends a little bit on the what kind of medications you're taking. Like corticosteroids
Mhm.
can cause you to gain weight. So I don't know in this particular case what may be causing a weight gain with this, but I think that there's definitely potential with medications, and certainly with rheumatoid arthritis, there that could cause weight gain, and I believe psoriatic arthritis as well. But yeah, I don't know if Dr. Bakewell also has any insights on this particular question.
Yeah, no, I think you said it well. I think we think of it more as the inflammation associated with obesity can directly promote and potentiate psoriatic arthritis. The way that psoriatic arthritis promotes and potentiates obesity can be from medications like the corticosteroids, but also as you're hurting, you tend to want to. It's ironic. I mean, we say movement is medicine, motion is lotion. Like your joints will feel better if you move, but the reality is when you don't feel good, you certainly don't feel like exercising and eating a kale salad, right? You're going to eat comfort foods, and you may not be taking as good a care of yourself because you're inflamed and you're hurting. And so there's definitely a cycle of wellness or unwellness, right? That people can fall victim to. You really need to address both. So I also wouldn't say don't treat your psoriatic arthritis, only treat your obesity. I think we need to be addressing both things in order to really get people feeling as good as they possibly can.
Yes, we hear that a lot when we speak to patients, that it's kind of a double-edged sword. They can't move as much and they're being told to move more. So this is a really interesting conversation in that way.
I've
Um,
actually stayed in bed for like 48 hours just because it didn't hurt.
yeah,
And I'm like, well, I feel good now. I'm laying down. I'm not doing it in 48 hours. I think the worst was 72 hours of
gosh.
non-bedtime. And it gets really bad. You start spiraling down with that. And you just got to get up, and it's hard to get back going. So, but now that I've lost some weight, I don't haven't had that happen. I'm getting up every morning.
That's so wonderful to hear. I think we'll probably wrap our Q&A at this point. Thank you so much for asking these questions. We are going to be doing more webinars like this, so please do stay tuned with us so that we can get to even more of your questions. If you have a pressing question that we did not get to, you can always feel free to email us at info@curearthritis.org, and we are very happy to try to find you an answer. This has been such an incredible discussion, and I just want to take a moment to thank each of our speakers, Dr. Faust, Dr. Bakewell, Jason. Thank you for sharing these experiences with us today. How incredible for us to get such a 360-degree view of this. We really appreciate it. We've talked about how PSA and weight intersect, why that matters, Jason's personal experience navigating treatment, and what practical steps you can take to feel your best. Jason, your story is truly such an inspiration for us, and I know it's going to help a lot of folks on this call too. Before we wrap up, let's do one more knowledge check. Let me launch this for us. I would love to hear, do you feel more confident speaking to your care team about weight management and arthritis after joining us today? I'm hoping that we were able to answer some of your questions, and I'm really grateful actually that we have a couple more questions kind of lingering that we can look into and hopefully bring some good insight to. So yep, we're seeing all of us saying yes. Yes, we do feel more confident, and we will have this webinar recorded and available on our website very soon. So if you want to go back to this to find out more about the questions that were asked, to look into the presentations that were shared, please feel free. Before we go again, I want to say another huge thank you to Lily for their generous support of this program. And of course, a big thank you to all of you for spending time with us today. ANRF has a wealth of resources on our websites, fact sheets, guides available, many of them in Spanish now. You can find them all on curearthritis.org. And again, this webinar will be up there very soon. So stay connected with us. Thank you for being here today. And until next time, we'll see you soon.